Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome again my dear students in my surgery lecture number 49, that is the injuries and the instrumental examination of the urinary tract. In this lecture we will cover the all types of the endoscopy, that is the cystoscopy, ureteroscopy, rhinoscopy, endoscopic examination of the urinary system, ureteric catheterization, injuries to the kidney and its management, injuries to the ureter and its treatment. All these points we will cover in this lecture. Now we start with the instrumental examination of the urinary tract, that is the endoscopy. Endoscopy has revolutionized investing method of lower urinary tract. Preparation for this endoscopy, the external genitalia, scrotum, groin and the upper parts of the thigh are first swabbed with the tincture iodine. Now particularly the external genitalia with retracted prepuce is cleaned with the soapy antiseptic solution, that is the 1% lignocaine with 0.25% chlorhexidine jelly is pushed into the urethra to provide the anesthesia and lubrication in the urethral tract. The urethra is milk and 5 to 10 minutes should be given for the action of the drug. Now the cystoscopy. Previously rigid cystoscopy were used. Through recently fiber optic cystoscopies have been made the procedure more comfortable. This instrument is introduced through the urethra in the similar fashion as a boogies. Cystoscope is particularly used to visualize inside of the bladder, though ureteric catheters may be introduced through the ureteric orifices and retrogradely perform the retrograde urography. Systemic inspections of the inside of the bladder is extremely important to exclude the pathology there. Use of the telescope with a wider fields of the vision may be required. The ureteric openings are usually situated at the 4 o'clock and the 8 o'clock positions indicated by a knob on the handle. Cystoscopes can be used in 3 types: visualizing cystoscope, operating cystoscope, that is the excision of the small polyp or tumors, cauterization of the tumors and for taking the biopsies from the tumors, and the third is the catheterizing the cystoscopes. Dear students, here is the animated picture of the cystoscopy. There is a rigid cystoscope has been introduced in the bladder. You can clearly seen through the urethra. This is the cystoscopic images clearly seen. For A diagram showing the internal urethra, second is the same, and third is the prostatic urethra, and diagram D showing the same prostatic urethra. This is the another image with the fiber optic cystoscope, flexible cystoscope is there, and the images of the bladder is clearly seen. Now the next point of this lecture is the ureteric catheterization. The ureteric catheters are long, narrow, radiated gum elastic tubes with stellats. The catheters are passed through the cystoscope into the ureteric orifices. Ureteric catheterization is performed to collect the specimen of urine from the individual kidneys, to perform retrograde pyelography, to locate the level of the obstructions within the ureter. The catheter may be pushed above the impacted stone for drainage as well as to instill the lubricant so that the stone may be passed out through the bladder. To relieve ureteric obstruction in case of the calculus anuria, and then the ureteroscopy. There are 2 types of the ureteroscopy. First is the anterior ureteroscopy and second is the posterior ureteroscopy. First, anterior ureteroscopy, which means inspection of the penile urethra for urethral stricture or chronic urethritis, and second is the posterior ureteroscopy, which means the inspection of the membranous and the prostatic urethra, mainly the verumentanum, which is an eminence in the posterior midline and the prostatic urethra, and the sinus procularis on its summit with the ejaculatory ducts opening on either sides are inspected carefully. Dear students, here is the image of the ureteric catheter, which is clearly seen, long, narrow, radiated gum elastic tubes and with stellate. This is the various types of the ureteric catheters with stellate. You can see there is the markings of the distance in centimeters is there. Now this is the ureteric catheterization by the cystoscope. You can clearly see on your screen. Now the next point of this lecture is injuries to the kidney and the ureter. About 10% of all injuries seen in casualty department involve the genitourinary system. First is the injuries to the kidney. Renal injuries are the most common injuries of the urinary system. The kidney is well protected by ribs, vertebral bodies, lumbar muscles and viscera. Below or fails on the loin, and the crushing roads traffic accidents are the usual causes of the injury to the kidney. Fractured rib and transvertebral processes may penetrate the renal parenchyma. It must be remembered that the kidneys and with the existing pathologies, that is the hydronephrosis, tuberculosis and the malignant tumors, are more readily ruptured following minor trauma also. Now the etiology: blunt trauma to the abdomen, flank or back in the most common mechanism of the renal injuries. Second is a gunshot and knife wounds may cause penetrating injury to the kidney. Third is a sudden brake in high speed vehicles may result in major vascular injuries to the kidney. Dear friends, here is a good animated pictures. First is the bruising of the kidney, third is the laceration, and the fourth is the torn attachment of the kidney, clearly seen the arterial and venous turning. This is the another picture which showing the gradation of the injuries of the kidney: grade first, grade second, grade third, grade fourth and grade fifth. This is the typical pictures of the turning of the renal parenchyma and renal cells of the kidney in the road traffic accidents. Dear students, here is the image showing the dramatic representation of the various types of the renal injuries. A showing the superficial cortical laceration, B showing the complete fissure or tear of the renal parenchyma and the pelvis, C diagram showing the deep laceration of the kidney, and D diagram showing the laceration of the renal pelvis causing urinary extravasation, and the E diagram showing the total avulsion of the renal artery and the vein, as we see in the previous images, animated images. Now the pathology and the classifications of the injuries of the kidney are: one is a minor renal injury and second is a major renal injury. Blunt trauma usually causes the laceration of the kidney in the transverse plane. Tears of the renal parenchyma usually follow the lines of the collecting tubule. The pathological classification of renal injuries is as follows, like minor renal injury and major renal injuries. Minor renal injuries, renal contusion and bruising of the parenchyma is the most common lesion. Subcapsular hematoma in association with contusion, superficial cortical laceration, incomplete fissure or tear of the capsule and renal parenchyma with perirenal hematoma but without any extravasation. Second is a major renal injury. This means deep corticomedullary laceration with extent into the pelvis to cause extravasation of the urine in the perirenal space. Complete fissure or tear of the renal parenchyma and pelvis to cause gross hematuria. Deep laceration of the kidney which cause large retroperitoneal and perinephric hematomas. Multiple laceration causing complete destruction of the kidney. Laceration of the renal pelvis or ureter causing urinary extravasation. Now the vascular injury of the kidneys: stretch on the main renal artery without avulsion may cause renal arterial thrombosis. Partial avulsion of the segmental branch of the renal artery. Total avulsion of the renal artery or vein. Then the late pathologies: if the patient survives, late pathologies may develop from various types of the kidney injuries, and these are the hydronephrosis, urinoma, renal hypertension. Fibrosis around renal arteries may consist into the cause of the renal hypertension. Arteriovenous fistula, this is only results after the penetrating injury involving renal artery and vein. Now the clinical features of this condition are the symptoms: pain, hematuria, general abdominal distension, present with a swelling in the loin after injury. Then the physical signs are: in general examination, hypovolemic shock or sign of the high blood loss may be noted. In local examinations, there may be ecchymosis or bruise in the loin region. Abdominal examination may reveal tenderness in the loin or there may be diffuse tenderness. Now the special investigation has to be done in these cases. Injury of the kidney are the urinary examination first. Blood is also there but not written in this slide. Blood should be examined thoroughly for leukocytosis, CBC count. Next is the straight X-ray abdomen, excretory urography, nephrotomography, ultrasonography and retrograde urography, computed tomography, CT scan, radionuclide renal scan, arteriography, arterial thrombosis for the arterial thrombosis, total pedicle avulsion and severe contusion causing vascular spasm besides absence of the kidney. Now the treatment of the injury of the kidney: first is the emergency measures and second is for local management. First is the emergency measurements. The objective of these are to treat shock and hemorrhage. The measures consist of: the patient must be hospitalized and lie flat in the bed. Movement is disallowed. A sedative is immediately. An appropriate antibiotic is started at the same time to prevent the infection of the hematoma. Intravenous infusion is started, which should be followed by blood transfusion hourly pulse and blood pressure chart should be maintained. Once the central venous pressure, that is the CVP, has been normal, excitatory urography IVP should be done urgently to know that other kidney is normally functioning. Now the local management of the injury of the kidneys are, first is the blood injury. As mentioned earlier, minor renal injuries constitute 85% of cases. These usually do not require any operation. Bleeding stops spontaneously with emergency measures. B. In case of the major renal injuries, there is a persistent retroperitoneal bleeding, urinary extravasation and evidence of the non-viable renal parenchyma for which operation is justified. The clinical signs are signs of the progressive blood loss, rising pulse rate and low blood pressure in spite of the blood transfusion. Swelling develops in the loin which indicates retroperitoneal bleeding or injury extravasation. When the kidney is found to be ruptured in several places or the kidney pedicles is damaged, nephrectomy should be performed. Then the second local management point is the penetrating injuries. These injuries requires more often surgical intervention as other organs are often injured. Now the next point is the injuries to the ureter. Ureterial injury is rare. It may occur in stabbing or gunshot injuries, but in majority of cases ureter is injured by the surgeon, that is the iatrogenic. Ureter may be injured in operations, that is the emergency cesarean section or for ruptured ectopic pregnancies. Extensive lymph node dissection may also injure ureter. Endoscopic manipulation of a ureter calculus with a stone basket may be result in the ureteral perforation. Passage of a ureteral catheter beyond an area of obstruction may perforate the ureter. Now the clinical features. If the ureter has been ligated inadvertently during operation, the post-operative course is usually marked by the temperature of 101 degree to 102 degree of the Fahrenheit, as well as flank or lower quadrant pain. The patient may also complain of nausea, vomiting and distension of the abdomen due to paralytic ileus. Sometimes ureterovaginal or cutaneous urinary fistula develops, which usually appears within the first 10 days after operation. It must be remembered that bilateral ureteral injury or ligation is manifested by the post-operative anuria. Dear students, you can see the good animated image on your screen, that is the partial transaction, total transaction, angulation of the ureter, ligation of the ureter, that may be the iatrogenic, the ischemic ureter. You can see here, this is the renogram. You can see there is a obstruction in the right side of the ureter, mid ureter. The both kidneys and the ureter is clearly seen. Here is the another images, colored images showing the ureteric anomalies. Now the special investigations are microscopic hematuria, straight X-ray, excitatory urography, ultrasonography should be done. Treatment, all the cases of penetrating injury demands exploration, needs surgical intervention urgently. Second is the cases of the surgical injury may be discussed in two groups. Group 1 is when the injury is recognized at the time of the surgery. In this case, an attempt is made to restore continuity. The cystoscopic catheterization of the ureter and the catheter is passed beyond the point of the injury. The distal end of the ureteric catheter is brought out per urethra and secured to a small indwelling Foley's catheter. It should be removed after 1 week. If the viability of the ureter is in question, the damaged segment is excised and the end are mobilized for end-to-end anastomosis with interrupted 4-0-Dexon. Firstly, the superior pedicles of the bladder and if needed the inferior pedicles are divided to mobilize the bladder up. This allows the fundus of the bladder to be brought up about 2 inches above the pelvis, where it is anchored to the psoas sheath. If this technique fails, a Bory flap is created. This tubularization of the bladder will allow 3 inches of the extra length for a tension-free implantation of the ureter. If this also fails, ileal interposition may be used. In all cases, a reflex preventing reimplantation of the ureter into the bladder should be performed. A submucous tunnel is created into which the ureter is implanted obliquely through the muscles of the bladder. A splitting catheter may be used and bladder drainage is also used for the 10 days. In case of the upper ureteric injuries, if ureteric anastomosis is not possible, ureterostomy is performed by swinging the proximal ureter across to the ureter of the other side for the anastomosis. Now the group second for the surgical injuries. In the group second, ureteral injury recognized after surgery, as mentioned earlier, these cases are often recognized by the continuous complaint of aching in the loin and continuous fever for the early post-operative period. Sometimes urinary leaks develop per vaginum and through abdominal wall usually between 6th to 10th day post-operative day. As this stage, if the ends are clear, cut and no length is lost, end-to-end anastomosis should be performed. In case of low down injury, the ureter is reimplanted into the bladder. In upper ureteric injuries, either end-to-end anastomosis or ureterostomy should be performed. If for whatever reason the patient cannot be reoperated within 3 days, it is wise to wait for as many months as possible. Dear students, here is the end of our surgery lecture number 49, that is the injury and the instrumental examination of the urinary tract. I think this is enough for you to understand all these points covered in these lectures. Thank you.